terms of allergies, because everyone's allergic to penicillin, just have a vague idea that if you are allergic to penicillin, go on a cephalosporin instead. So if you're allergic and you can't have amoxi, for example, with sore throat, sometimes they'll chuck you on erythromycin or something, if any of you are allergic. Hello. And also, but if it's really bad, you don't want to cross over with any kind of beta-lactam. I'll explain what that means in a minute. So you pick at something completely different. That's probably about as much as you need to know. And the side effect for all of them is that they kill off not just the bad bacteria, but the good bacteria. So in your gut, you get something called pseudomembranous colitis, which is caused by C. difficile, and definitely know that one, and know it's an anaerobe. So what do we use to kill anaerobes? Yeah, metronidazole, because it's stuffy and you can't breathe underground in the train system. And if you ever wondered what a pseudomembrane was, and pseudomembranous colitis, that's what it looks like macroscopically, which is pretty gross. And you can also kill off the bacteria on the skin, so you can get thrush as well, which is treated by clotrimazole. That's been on a practice exam in the past, so probably stick that one in your brain. Oh, yeah, there we go. Cool. So we'll quickly go through which class is which and how to remember it. So again, it will be a little bit weird. So like I said, all the penicillins end in cillin. So amoxicillin, benzoyl penicillin, fluvoxacillin, all the cillins are penicillins. That's easy enough. Probably the two main ones to know are benzyl penicillin and phenoxymethylpenicillin. And it's a bit confusing because one's called penicillin G and one's called penicillin V. So benpen is given intravenously or intramuscularly, and phenoxymethyl is always given by mouth. And there's two other ones that, just so if you ever hear them thrown around, don't know what it means. There's benzathine penicillin, which is basically like a long-acting benzyl penicillin that works over a couple of weeks. So that's important in a few things next year for peds. We don't need to know it now. Then something called procaine penicillin is just benpen, and they also give you some numbing, so it's like hell when they inject it. So benpen and penicillin V. So how do you remember which one's G and which one's V? This is again a bit of a stretch. Has anyone seen V for Vendetta? So I think of the character from V for Vendetta who's called V, and there's a scene where he like puts a massive smoke bomb in the TV station, there's gas everywhere, and it's used for group A strep, which is gas. So penicillin V is used for group A strep, and that's the only thing it's used for. Probably another one to know. And benpen, I think of Ben 10, and he's holding a big pen or a big injection stick, or a syringe, as you smart guys might call it. So that's the one that you use IV. Cool. Does that make sense? Sick. And then there's the aminopenicillins, which are a bit better. So that's like amoxicillin or ampicillin, which are pretty much the same thing. And then there's the anti-staph penicillin. Whoa. Sorry. Oh. Well, that's a worry.
Do you have a shine there?
Oh, let's just close down. Sorry, give me a sec. There we go. Is that better? Awesome. Sorry, guys. Let me skip through. So fluvoxacillin is another one to definitely know. And just remember that's good for MSSA, or Staph aureus, that's not the bad one, and we'll have a picture of that a bit later on. And then if you're really keen, you've heard of Augmentin or Tazocin. Probably you've definitely heard of Tazocin if you're at the Alfred, because it's what they use in all the patients with CF for the Pseudomonas infections. Plus another little bit. So the way it was taught to me was imagine that the bacteria have secreted a little Pac-Man to eat up all your antibiotics. So you're giving me a penicillin plus a little bit that's going to block up the Pac-Man so your antibiotics can't get eaten up. And that's called a beta-lactamase. So you're stopping that, breaking it down, so it's a beta-lactamase inhibitor. So Augmentin is amoxicillin plus something called clavulanic acid. And then Tazocin is piperacillin plus tazobactam. That's like a really hardcore version of Augmentin that you use for really bad infections. So if someone's got, I think, febrile neutropenia and stuff, that's one of the medications they use. Cool, cool. Does the penicillins make sense? Awesome. These are the ones that have like 5 generations, which is a bit weird, and there's like dozens of these, but don't memorize all of them because that's silly. So I think of the video game Spore from like 10 years ago, if anyone remembers that. And that was a video game where like you started off as little like bacteria, and then you evolved into different creatures and ended up being like in spaceships and stuff. So it helps me remember that you go through the generations with cephalosporins. And the ones to remember are cefalexin, cefazolin, and ceftriaxone, which hopefully ring a bell. So cefalexin is the one you probably use more in GP. That's the first generation, which is oral. And then cefazolin is IV. And then ceftriaxone is also IV. So the way to remember that is cefalexin, sort of like Cefalex 1. Cefazolin is also like sort of Cefazol 1, so the first generation. And then ceftriaxone as a 3-net for third generation. So that sort of makes sense. And if you're really keen being and want to study heaps, I got this from a lecture from one of the ID doctors at the Alfred. It was amazing. He was an amazing teacher. And this is the thing he gave us. So it just shows that the early generation is really good at gram-positives. And then as you go on further, they get really good at gram-negatives, but not so good at gram-positives. So they sort of slip sideways. And a good one to know is this cefalexin is sometimes used for UTIs. If you ever thought about it, because UTIs are mainly caused by E. coli, which is gram-positive, so which is gram-negative. You're like, oh, why is a cephalosporin being used against a gram-negative? They also have action against Klebsiella and E. coli if they're first gen. That's just for interest. That's the same thing, but just with this information, which is just sort of at the back of your mind that cephalosporins aren't good against certain things. So that's like when you're treating meningitis, for example, one of the things is listeria. And you might be like, why can't you just give ceftriaxone for everything? And the answer is no, because ceftriaxone wouldn't work against listeria, which is also why you give benpen in that meningitis treatment, which we'll go through later. It's also not good against mycoplasma or chlamydia. So also in pneumonia, you might remember that the really hardcore community-acquired pneumonias, you use ceftriaxone and azithromycin. The reason you use azithromycin is you want to cover those atypicals, because the cephalosporins aren't going to cover those atypicals. So that's called atypical cover when you do that. The same thing with doxycycline, with the slightly more mild community-acquired pneumonias. You use benpen for most of them, and then you use the doxy to polish off all the weird ones. And obviously you can't use it against MRSA, which makes sense. So remember Cefalex 1, Cefazol 1, and ceftriaxone. And cefazolin is the one you probably hear them using in theatre all the time when they want to have antibiotics cover because they're cutting in the skin. They want to kill off all the gram-positives on the skin that might cause an infection later. Does that make sense? Cool. So this one is useful because a lot of things end in mycin and antibiotics, which is a real pain. So the story I imagine is this guy who's bought himself an AC computer and then he really hates it and he's really pissed off about how bad it is. So he goes and throws it into the ocean and he buys a Mac instead because Macs are awesome. So all of the ones in Australia end in thromycin. So he's throwing that computer away. And also only 4 used in Australia are ACER. So ACER, zithromycin, clarithromycin, erythromycin, and roxithromycin. Cool. Does that make sense? So the thromycins are macrolides. Cool. Aminoglycosides, there's only one to remember, and that's gentamicin. So I think of the gent is like gentlemen and mice is like mice. So I think of like the 3 blind mice wearing their waistcoats and their fancy hats and stuff. So my character for gentamicin is a mouse wearing like a top hat, which will be important later. Does that sort of make sense? Cool. So 2 ways to remember they're really good against gram-negatives. I remember that a mouse's tail sort of stuck out sideways looks like a negative sign in my head, but probably an easier way is you take the GEN at the start of gentamicin and flip it around and it becomes neg. So it's good against gram-negatives. So if someone's got like an E. coli septicemia or something, you chuck them on gentamicin. Or if they've perfed their appendix, for example, you want to cover the gram-negatives from the normal flora, you chuck in some gentamicin among other things, but that's also a question for later. What are the 2 main side effects for aminoglycosides? Anyone know? Yeah, ototoxic and nephrotoxic. This is a really cool picture I found of the ears and the kidneys beating each other up. This is the main aminoglycosides, if you can, but just remember gentamicin is the main one. So in a question on an MCQ, there'll sometimes be like, oh, someone got treated with some really hardcore antibiotics and now they can't hear and their balance is all whack. And in real life, it could be like a loop diuretic or something, or it could be aspirin, I think, among other things. But an exam question will make it really obvious it's antibiotics. So the only thing that really causes hearing loss from an antibiotic or ototoxicity is an aminoglycoside, except for vancomycin in very rare circumstances, which we won't be examined on. So I just imagine that mouse in a top hat with really massive ears. That picture helps me remember when I'm stressed that if it's ototoxic and it's an antibiotic, then it's probably gentamicin. Does that make sense? Sick. Alrighty, tetracyclines. So I think of someone riding around on a four-wheeled bicycle, because tetra is four and cycling, like a bicycle. So the reason it's called that is because of that four-ring shape in the molecule, which you don't need to remember. You probably do remember it causes like weird teeth staining in people with young teeth. So it's a calcium chelator and gets stuck in your marrow and gets stuck in your teeth and does weird things. So people who have got developing bone marrow in them, so either a little kid, younger than like 6, I think, or a pregnant mum with a little baby developing bones inside of her, shouldn't be put on tetracycline or doxycycline. So that helps you remember on your bike, it's dangerous. So don't chuck a little kid on a bike, and don't chuck a pregnant woman on a bike. So don't give these people tetracycline. Excuse me. In exams, sometimes it causes esophagitis. In like the Guinness World Records once was that really weird guy who like eat metal and eat bikes and stuff. He probably got a lot of reflux. So I just imagine this guy doing crazy stuff and eating a bike. And that picture helps you remember in an exam that if it's esophagitis from an antibiotic, then it's probably tetracycline or doxycycline. Cool. Fluoroquinolones are the weird ones. I don't think we'll be examined on them, but just for the sake of being able to recognise what they are. So ciprofloxacin or norfloxacin, so they all end in floxacin. So this is a bit of a stretch. But I think of quin sort of sounds like quill, like a bird's quill, and flock sort of sounds like a flock of birds. So that sort of helps me remember that if it ends in floxacin, it's a fluoroquinolone. So like ciprofloxacin again would be an example of that. And if you're wondering why all those pictures are sort of like weird, sad, lonely pictures, there's lots of weird, sad, lonely side effects from these antibiotics. So they cause like seizures and psychosis and weird things. And also cause your tendons to snap. So they do weird things, but they're also useful in the right circumstances. So ciprofloxacin is used in pseudomonal infections. Again, if the alpha is the only oral option for that. And norfloxacin is used in traveller's diarrhea, but that's more of a GP thing for next year. And just for the sake of completeness, I've chucked in the carbapenems. So if you might have heard of meropenem and imipenem, that is like the really awesome things we use when everything else isn't working. They pretty much just kill everything. So why wouldn't we use carbapenems all the time? They're so good. So there's a thing on ETG that I think it's like Mind Me, is the mnemonic, which I haven't put here. It just pretty much says, only use what you need to use and nothing more strong. Check the guidelines and don't use it against like a virus, which is all pretty much common sense. So something that like penicillin V is narrow spectrum, so it's like a sniper, and it's only sniping off one thing, which is group A strep. Whereas like ceftriaxone or meropenem, a broader spectrum, are just like the flamethrower that kills everything. Obviously, the reason we don't use them all the time is every time we use them, we give an opportunity for bacteria to develop antibiotic resistance, which is obviously bad. Cool. So I'll do a bit of a pop quiz to see if we remember which one's which, if we saw it on an exam or on a ward chart, and we'll go over antibiotics, and then we'll go through the MCQs. Sound good? Awesome. So I don't really want to pick people off one at a time, but I might, because otherwise it'll be a bit weird with awkward pauses. So if we start at the back and work forwards. So, sorry, I don't know your name. Get on the rainbow top. Oh, which one's what class is this? What does it end in? Yeah, awesome. So all the penicillins end in cillin. Easy peasy. So the picture I think of for flucloxacillin is a cyclops with the flu. And I'll explain what this means later, but let's let you just add on that picture and all this weirdness. Cool. What's norfloxacin? Yeah, fluoroquinolone, so it's like ciprofloxacin. So the flox reminds me of birds and the quin is like a quill. Again, that's harder to remember. I can't think of a better way. But yeah, let's say fluoroquinolone. Awesome. Just a sheet. Close. This is one of the hard ones where it ends in mycin. It makes life difficult. So it's thromycin. It's throwing away the computer. Yeah, macrolide. Awesome. Just think of the Mac computer. And remember, ASA is all the ones. So isotro, clotho, overthrow, and roxithromycin. Cool. Back down the front. What class is ceftriaxone? Yeah, awesome. All the cephalosporins starting kef. And my picture for that is 3 cavemen holding an axe, which will be important later when we talk about Neisseria meningitidis and why it's useful. So ceftriaxone, awesome. Our class is vancomycin. Oh, close, but no. So what's the picture for vancomycin? Jesus. Yeah, so Jesus holding a candy cane. Candy cane's like sugar. Cool. It's got glyc in it. It's hard because this one is actually come up on the exam, which is why I'm stressing it. So it's glycopeptide. So stick that word in your brain because it might come in useful. So glycopeptide is vancomycin. Good. What class is doxycycline? So tetracycline, awesome. Do it on a four-wheeled bike. This is fun. What class is imipenem? Yeah, carbapenem. Sweet, nice work. What class is gentamicin? That's the A. Yeah, nice. Cool. So that's a bit hard, but I recommend reading over those slides a few times because they're useful to know the classes for those because antibiotics have come up in all specialties. So it's probably worth getting that organised with your brain. Cool. So I know Steph went over this, so I'll really quickly squiz through gram stains. It's important for which antibiotic goes when. So beta-lactams are these three, if you see this in the exam, and it will be in a question later from the practice papers. So beta-lactams are these three: penicillins, cephalosporins, and carbapenems. And they all have this, the reason they're called that is they have something called a beta-lactam ring in their molecule thingy, which looks like this. So I think of beta-lactams cracking the dam because they smash open the cell wall of antibiotics and then osmotic pressures rip the cell apart, which is pretty cool. So yeah, they do that pretty much. So to think about why that's important and why they're used against gram-positives, you have to think about gram stains a little bit. So we have to go back to first year, which is annoying. So what are we up to? Yeah. Which one is gram-positive and which one is gram-negative? This is a bit of a main question. So. This one? Yeah, nice. On the left. I wouldn't expect you to know that. The reason why that's important is think about beta-lactams cracking the dam again. So the thicker a wall is, the more important that is to the structural integrity of the bacteria. So think about look how thick and how important that big peptidoglycan cell wall is and how exposed that cell would be if you cracked it apart. So that's a gram-positive, and that's why cephalosporins and penicillins in particular are so good against gram, because they're pretty much smashing the entire wall and the entire structural integrity of the cell. Whereas in the gram-negative, it's like a little weeny bit of peptidoglycan, so it's still useful, but not always. Does that make sense? Cool. That's another picture. So here's the peptidoglycan layer, stains blue in a gram stain, so it's sort of like a purpley blue for gram-positive and sort of pinkish on gram-negative. And I wouldn't be surprised on OSCE if you had like a meningitis station or something, and they had like a gram stain at the end. You're like, what bug is this that came from the CSF? So it's probably useful having a bit of a way to remember. So I think of pink being like a really grungy punk singer, which is probably not. But let's remember that pink's not a very positive person. So pink is gram-negative, and then blue is, or purple is positive. Does that make sense? Cool. And just on the shapes really quickly. So there's cocci and bacilli. So cocci looks like an eye, and also the big O in the cocci sort of gives that gamma away. So that's how I remember. And bacilli look like bars. So that's like a bar shape or a rod shape, which is how I remember. And then just a good frame of reference if you're stuck in an exam is that most gram-positives are cocci, and the opposite, most gram-negatives are rods. And I remember that because a rod looks like a big negative sign. So that sort of makes sense. And then coccis can be sort of subdivided a little bit further. So they can be a staph or a strep. And there's like different subdivisions of those. So staph looks like a splat to me, and it's Greek for bunch of grapes. Whereas strep looks like a string or a strip of bacteria all in the big line. So if you look at staph, you can see it's like a big sort of splat or cluster of grapes, whereas strep is more like a strip with things lined up one after the other. Does that make sense? Awesome sauce. So this looks very imposing. And this is more sort of one to draw out in your own time. Just remembering this is all the gram-positive stuff, and they can either be circles or bars, and most of them are circles. Just remembering that the most important ones are the staph species, which are the sort of the Staph aureus ones, and the sort of less important staph that you don't really see very much except for Staph saprophyticus. Does anyone know where that comes up? Yeah, awesome, UTIs. So UTIs are like 80% E. coli. And in young women, you might also see Staph saprophyticus, which is probably sort of worth having a vague memory of, but E. coli for UTIs usually. And so you've got the big staph group and the big strep group, which we did sort of indirectly get examined on our OSCE, maybe, or maybe not. I don't know if I'm allowed to say. We didn't get examined on that in our OSCE. So I'll go through what that means in a sec. It's the same picture in a different way. And these are all the gram negatives, which I'd be less stringent in remembering because it's probably less important. Just I just have a vague memory of E. coli, Klebsiella, or Pseudomonas, all those other ones are gram negatives, whereas the only ones that are cocci shaped are the Neisseria ones. I remember that because Neisseria meningitis causes meningitis, Neisseria gonorrhea causes gonorrhea. So I remember that gonorrhea affects the part of your anatomy that sounds like cocci, and everything else is a gram negative. So that's a lot to remember. Break it down this way. So when you learn all like the muscles in the arm and stuff, you don't really bother learning, oh, the median nerve does this, median nerve does this, median nerve does this, all nerve does this. Just go, all the flexors are median nerve in the forearm except 1.5. So just remember the exceptions, and that's a lot less brain space. So I just remember all the important ones that are gram positive through SS Black. So staph is positive, strep is positive, bacillus is like a species, not the shape, and that's like, I think, anthrax and stuff, but don't really worry about that. Listeria, which you will see. Enterococci, again, don't really worry about that, that's like a weird subspecies. And Clostridium, like Clostridium difficile, for example. So the SS Black are always gram positive. It's really one of the takeaways from today. If you remember that, it probably makes life easier. You can write that out in exam and then sort of go through it in your head. Makes it easier too. So I will explain what this means, just because it's always been really confusing to me, what group A beta hemolytic strep means. So group A and beta hemolytic are two completely different things that just both happen to correlate on a particular species of strep, which is strep pyogenes. So if it's beta hemolytic, it completely turns blood clear because it munches up all the blood. If it's alpha hemolytic, it turns the blood into, or turns the hemoglobin into biliverdin, or turns the bilirubin and the hemoglobin into biliverdin, which is green. So verdin is like verdant for a tree. Also, it just does nothing, that leaves the blood alone. So beta hemolytic completely digests blood. And then group A is just something about the way cells look on their cell walls, which isn't that important. So just know that group A beta hemolytic strep is strep pyogenes. And that strep pyogenes makes something called streptolysin O, So something called anti-streptolysin O titer, or ASOT, measures the presence of strep. So if theoretically you had an OSCE and had something to do with strep, and then you saw that on the results you were given, didn't know what it means, like I didn't know what that meant last year, just know that ASOT is to do with strep pyogenes. It'll be cool. And then just knowing the fact that the reason strep pyogenes is important is it causes immune things to happen as well as the strep throat. It causes rheumatic fever, which is more of a peds thing. It causes, and scarlet fever is more of a peds thing too, but it causes post-infectious GN, which is an important differential in your OSCEs. And also it could come up on an MCQ as well. So yeah, if you take anything away from that, beta-lactams crack the dam, so they smash that important gram-positive layer and kill the gram-positives. Cool, I'll breeze through this because it's not that important, and we'll go on to the MCQs. So, like I said, beta-lactamase is a way that bacteria have evolved to munch up your antibiotics. So just remembering that augmentin and tazocin are penicillins plus another ingredient, which is to block up that munchy thing. And just remembering that cephalosporins are also beta-lactams, so they're also susceptible to those bacteria. If you're really interested about how other things work, these ones, which I'll have on the table later, work against protein synthesis, and fluoroquinolones, which are the weird ones, work against DNA synthesis. So I think macrolides break down your 30S ribosome from memory, and then aminoglycosides, I think, break down your 50S. And as do, erythromycin is 50S, and then aminoglycosides 30S, sorry. But don't memorize that, that's a waste of your time. But that's just for completeness. Cool, so if on an OSCE you had a gram stain, these are the ones to probably know, and the antibiotics that work against them. So for Staph aureus, or golden staph, there's two types. So I think of Pokemon, I think of Pichu as like the weak one, and Raichu is the evolved, stronger version of that. So you use flucloxacillin against MSSA, and you use vancomycin against MRSA. So you see fluclox used a lot against skin infections and that sort of thing, and osteomyelitis and septic arthritis for fluclox is used for MSSA. So I think of, again, a little Pichu looking all sad because he's going to get eaten up by a big cyclops with the flu, which is flucloxacillin. And for vancomycin, I just imagine Jesus for vanquishmycin being really rude to Raichu. That sort of makes sense. Awesome. So strep pneumo, it's the same thing as pneumococcus, if that's something you find confusing like me. So it's the exact same thing. And there's a few things that work against that. I think amoxicillin and benpen and all the penicillins, because it's gram-positive, work against that. And it can also be vaccinated against, which is cool. So strep pneumo is an important one to know. That's gram-positive cocci. Neisseria meningitis is the same thing as meningococcus, if you've heard that before. So it's not on that list of SS Black. So it's not staph, strep, listeria, enterococci, clostridium, or bacillus. So if it can't be a gram-positive, it has to be a gram-negative. And it's also called meningococcus. And the reason it's important is that you might get that picture in an OSCE, I wouldn't be surprised if you had a meningitis station and then so you've diagnosed meningitis and they showed you that picture. They're like, all right, what would the gram stain be for this bug? So Neisseria meningitis causes a non-blanching petechial/purpuric rash. That's definitely something to know. That's really important. Does that make sense? Cool. So the picture I use to remember that, because it's a diplococci, I imagine two diplodocuses, like the dinosaur, and they're both pink. For gram-negative, they're both splotchy red. For the non-blanching purpuric rash, and it's treated with ceftriaxone, like in meningitis and stuff. So imagine those three cavemen with their axes chasing after the dinosaurs. You can also use benpen against it, but it's not as good, so I've included benpen there as fun. But ceftriaxone is used against Neisseria. Cool. And this one I don't think I've seen in a practice exam, but I wouldn't be surprised because it's an important nosocomial infection that you get in hospitals all the time. So I imagine pseudomonas like a fake orgasm, so it's a pseudomoan. So a moan comes from your lungs and it goes into your ears, and you might also get friction burns from the sheets. So it's found in your lungs in cystic fibrosis patients who get pseudomonas. Causes otitis externa, which is more of a thing next year. It's also a very common cause of burn infections. It also causes like a grape-coloured exudate, like a greeny-blue exudate, and it smells like grape too, apparently, which is a bit weird. So if that came up in the exam, it might be a bit of a buzzword. And then all the treatments. Cool. So based off all that stuff, before we go to the MCQs, these are all sort of the questions I had up on the start that we've sort of gone through. So go through them one at a time and see if we can find the answer, and hopefully that consolidates the most important bits. So, who are we up to? No, I'm sorry. Don't point. So treatment for strep pyogenes. So I imagined a character from a movie who's taking on the gas. Yeah, V for Vendetta, yeah. So penicillin V, awesome. So that's really important. That's the sniper for like that particular bacteria, nothing else. So treatment for MSSA, so little Pichu, who's going to eat it. Flucloxacillin, awesome. Cyclops of the flu. Treatment for MRSA. Vancomycin, awesome. What causes red man syndrome? We're back. What causes red man syndrome? Yeah. Yeah, vancomycin again, awesome. What's an IV penicillin with really good gram-positive coverage that you might use in pneumonia, for example? Keyword being IV. If you're carrying a little injection pen. Yeah, benzylpenicillin or benpen, awesome. And IV aminoglycoside, which you use for really serious gram-negatives. So imagine the first three letters in that word backwards are neg. It starts with G-E-N. Gentamicin, awesome. What do you use for all anaerobes in the Monash exam? What are we up to? Metronidazole, awesome. What causes permanent hearing loss that's an antibiotic? Gentamicin, yeah, the aminoglycoside class, awesome. And what's the third gen cephalosporin with a really broad spectrum flamethrower coverage? Ceftriaxone, sick. Awesome. So if you can get all that, you're pretty much a genius and you'll be fine for the exams. So that all sort of makes sense. So I need to go over any of that again before we go through the MCQs. Awesome. Cool. Oh yeah, one more question. Are the bacteria in the gut predominantly positive, negative, or anaerobes? What are we up to? Yeah. Hint, it might be a trick question.
Yeah.
Yeah, so yeah, exactly, it's all of them. Good. And that'll be important when you're thinking of a question a bit later, because that's the question that comes up fairly often. So all the bacteria in the gut are all of them. So you have to cover all of them. Oh, sorry, I had a few more bits before the MCQs. What is this? If you saw this in the stain, and it was a meningitis osci. And it's a diplococci, like the diplodocus. Yeah, exactly, Neisseria meningitidis. Just a little diplodocus who gets killed with ceftriaxone. Awesome, 3 guys chasing after him with an axe. Cool, cool. So hopefully you don't all think I'm crazy, but that's how I remember antibiotics. And the useful thing about that is that you remember it a long time after the exam's over, because it sort of sticks in your mind. The more bizarre, the better. So I recommend learning stuff like that, because it's way more fun than just rote learning. Cool, cool. Ready for MCQs? Then we can all go home and enjoy what little sun's left. Oh yeah, and also if you make up pictures and stuff yourself, it's obviously easier to remember than something someone else tells you. So I'd recommend doing that very, 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 very strongly. It's the most useful study tip I ever learned. Cool, cool. Where are we up to? Awesome. Cool, so 23-year-old woman presents with an uncomplicated UTI. What class of drugs would be appropriate first-line therapy for this condition? And all these questions, I'm going to have a little way to remember them afterwards as well, just for fun. All close. Yeah, beta-lactam, awesome. So you can do sort of pretty much do exam technique with this one, because only 2 of these things are antibiotics, which are beta-lactams and the glycopeptide, and everything else is like, that's statins, that's benzos for psych, and that's diuretics. So only 2 things here are antibiotics. So the important thing is which is very hard if you haven't really gone over stuff before. So this is all from ETG. Use ETG, it's awesome. Very highly recommend. It's got all the treatments for all the thingies. So these are the top treatments. So the top treatment is actually trimethoprim, which isn't there, which is annoying. So the second choice would be cefalexin, which is a beta-lactam. So it's one of those things that breaks the dam, which is like penicillin, cephalosporins, and carbapenems. And then augmentin is penicillin plus something else. Yeah.
So is it a gram-negative?
Yeah, exactly.
But you still use beta-lactams?
Yeah, yeah. So the reason that's important is, remember that thing I showed you way back before where there was the big table and it sort of had the things shifting across it from the different generations? Yeah. So cephalosporins are mostly good at gram-positives, but the further generations that go on, the better they are at gram-negatives. And the reason they're better than penicillins in a way is that even the first generations, which are primarily against gram-positive, also have a little bit of gram-negative cover, which was Klebsiella and E. coli. And E. coli is the main thing that causes the UTI. So that's very confusing. I didn't understand that last year at all. So even though it's a gram-negative, you can still use cefalexin in that case. It's probably important. Yeah, awesome. Cool. So beta-lactam for that case. So what would this one be? That makes it a bit easier. So class of antibiotics used for treating resistant bacteria often can cause kidney toxicity. Mm-hmm. Awesome. So the main one being vancomycin. Yeah, awesome. I had a bit of a non-PC way of remembering that, which was all those photos of Jesus. Sometimes after he's been crucified, he's got like a little scar under his ribs. So I think of that being like the kidneys, which may or may not help. Yep, so glycopeptide is vancomycin, which is used to kill resistance stuff to MRSA. It's also nephrotoxic. Cool, does that make sense? Awesome. Yeah, cool. Particularly, in what particular type? Assuming it's not viral.
Oh, strep throat.
Yep, strep throat. Cool, cool. And what do you use to treat that? It's group A strep, or gas.
Oh, yes.
Yeah, with Vendetta, penicillin B, awesome. But why, if say you gave amoxicillin instead, and they came out in a rash, what would you think that would be? If you misdiagnosed it? Yeah, exactly, infectious mononucleosis, so glandular fever, awesome. So amoxi plus glandular fever gives you a rash. So that would be a very easy MCQ. And also why not, because it's always worth taking a drug history too. So for another these, I'm sorry. For the heck of it, what class is cefalexin? Yeah, cephalosporin. Cool, cool. Okay. Yep, awesome. Subglandular fever. The splenomegaly gives it away there. This one's a bit harder. And given it's an antibiotics, lecture will also ask what you'd use to treat it. So not nice like that. This one's pretty hard. Yeah, exactly. So that's a good point. It could be Neisseria gonorrhea, especially in a young sexually active male. That's a common cause of septic arthritis in a male, but gonorrhea is not here. This one's hard. Does anyone know? Yeah, awesome. Staph aureus, nice one. So that's the most common cause, I think, even in young men, although gonorrhea is a really important differential. So gonorrhea causes septic arthritis, whereas chlamydia causes reactive arthritis. So I think if gonorrhea is a worse infection, it causes a worse thing, while chlamydia causes reactive arthritis, which is a bit gentler. That's also a gentler infection. Yeah, so Staph aureus. So I think of C3PO. This is an image I found really useful. It's got golden skin and golden joints. So the most common skin infection or cellulitis is Staph aureus, and the most common joint infection is also Staph aureus. So use for Staph aureus, what do you use to treat it? Fluclox, awesome. Staph aureus is Fluclox, great. 25-year-old man has tetracycline, now he's getting blood-streaked vomiting and retrosternal chest pain. What's the most common side effect of this antibiotic?
Esophagitis.
Yeah, cool, esophagitis. So I actually had a lot of trouble with that question when I first went over it. So that's good, esophagitis, nice one. So again, think of that guy eating his bike and getting esophagitis because he's a crazy person. Cool. Alrighty. 29-year-old man is admitted to the emergency department with increasing headaches and neck stiffness, no allergies, he's agitated, he's got a positive Koenig's, and he's photophobic. You notice that big rash that's non-blanching on his hands and his feet. So what's the most likely cause? Are we up to?
0.
Yeah, awesome. Cool. Nice one. What would that look like on a gram today? Multiple. Yeah, awesome. Gram-negative Diplococci. Spot on. Nice work. And we always get taught this, and I don't know if you've ever been examined on it, but it's probably useful knowing just in case. What's like the treatment for meningitis empirically?
You can have penicillin.
Awesome. And there's something else used that's not an antibiotic. Awesome. Spot on. 100%. Really good job. So I think of CBDV. So I think of a guy with a big city on his head for meningitis and then CBD, like Central Business District. So ceftriaxone, benpen, you want to get rid of the swelling, so you give Dex as well. And if you add vancomycin, if you're worried about MRSA. Yeah. And you give the benpen to cover listeria. That's probably the other important thing. Cool. And just for the sake of it, the way I remember the bacteria that cause it mostly in adults is Shane has nice legs. So strep pneumonia, Haemophilus B, Neisseria meningitidis, and listeria. Awesome. And that's another way that the guy who runs MyVespa told us to remember it, which is stiff neck, headache, light sensitivity for the 4 bacteria, which is also pretty cool. Koenig's and Brzezinski's, I think Steph went over. Does everyone understand Koenig's and Brzezinski's and why they're used? Cool. 25-year-old female, dysuria and urinary frequency, ain't got a fever, and she's got some supracute pain. Yeah. Yeah, awesome. E. coli. So what would you use to treat that? There's a few things. Yep, trimethoprim is number 1. Yeah, or cefalexin. Sweet, good job. And the most important one's an uncomplicated UTI. So no E. coli is by far the majority, but also have the back in your head. Staph saprophyticus is the second most common cause, particularly in young women. Cool. I see. So a 7-year-old man presents with a red hot left leg. He's got similar episodes and frequently in the past. They've responded to antibiotics, which is nice. So that shows you it can't be strain of this thing. On examination, he's febrile. He's got an inflamed lower leg that's poorly localized, probably. He's also got a bit that's broken in the skin, which is probably how he's got this skin infection. So what would we use to treat it? Yeah, awesome, Fluclox. So golden skin, golden joints. C3PO is Staph aureus for MSSA. we use flip-clox. Why wouldn't we use VANC in this case? Yeah, awesome. And it's responded in the past. We know it's probably not MRSA. It should be rare in the community anyway, although not impossible. Cool, so that's what C. virus looks like. You've never seen it before. And yeah, flip-clox is number 1. Cool. 21-year-old woman has had antibiotics and now she's got a cheesy looking discharge with an itch. So what do we use to treat that? Which I haven't really gone over. It's the only one here that's not an antibiotic, if that helps. It's just an antifungal. Yeah, awesome. The clotrimazole. Yep, so the azole means it's antifungal. Nice. Cool. And yeah, so antibiotics, diabetes, and immunosuppression are all the risk factors for thrush, and you use an antifungal, so clotrimazole topically is the number 1 treatment. Yeah, so 35-year-old woman presents with left lower lobe pneumonia. Her status is she's got 16 breaths per minute, her sats are 94, temperature is 39, so she's febrile, blood pressure is 110 on 80, pulse 85, CRP is very, very high. White cells are also high. Everything else is normal. She's got no allergies. So what's probably the bacteria? And what's the treatment for 3 different stages of pneumonia? What are we up to? Yeah, awesome. Nice work. Why's that? Yeah, awesome. So it's a typical pneumonia. There's no weird things going on. Most common cause of pneumonia is strep pneumoniae, which is awesome because it's got the name in the name, which makes it easy. I remember Sydney Morning Herald because these 3 bacteria just come together all the time. So I think they're also in China's media from memory for next year. So strep, Moraxella, Haemophilus influenza, always all cause the same things. I think bacterial conjunctivitis is another one of those. So that's a good little triad of things to keep in mind because they always come at the same time. Yeah, and it's almost always strep pneumonia. It's the most common cause anyway. I won't go through the atypicals and typicals because I think Steph did that as well. But just buzzwords for pneumonia because you are expected to be able to differentiate the different bacteria, which is really annoying. So strep pneumonia is the most common. So if there's nothing else bothering you anywhere else, it's probably strep pneumo. It's also got rust-coloured sputum, which you might have heard before. Chlamydia psittaci is in parrots. So I think of the psittaci sort of looks like parrot shit because it comes from excretion from parrots. And my GP tutor once had a guy who had pneumonia, and then he ended up having a Chlamydia psittaci strain of it. And he's like, "Oh, have you seen any birds recently? What have you been doing?" He's like, "Well, the only time was that my pet budgie died 2 days ago, so I gave him CPR to try and save him." And that's how we got Chlamydia psittaci, which is really sad. I'm not sure if the little parrot made it or not, but that always helped me remember that Chlamydia psittaci is parrots and birds. Legionella is diarrhea. So Legionnaire's disease causes diarrhea, which is really important because sometimes the only thing in a question that's going to differentiate from anything else is diarrhea. So I don't know if in real life that actually matters, but in Monash exams, diarrhea is Legionella. Klebsiella is Ella and jelly, so red jelly sputum for Klebsiella. And just remember, Q fever is abattoirs, and pneumocystis jirovecii is HIV. That's treated with Bactrim. Cool. So 17-year-old woman presents with central abdominal pain moving to the right iliac fossa. So the diagnosis is appendicitis. Cool. She's febrile, tachy, CT shows as a collection, and she's booked for theatre in 2 hours. So a collection in right iliac fossa, so something's burst. So all the bacteria that were in her gut are now in her peritoneum, which is bad. So for some reason, we need to know this question, even though it seems not necessarily something that's at student level. So what 3 antibiotics in a Monash question do you give for gut flora that have spread uncontainably? Oh, sorry, what indeterminate number of antibiotics? Yeah, sorry. So penicillin, Janton, Metro. Do you know why you give those 3 in particular? Awesome. Gram-positive, gram-negative, and anaerobes. In real life, that's not always the ones they use. Sometimes they use ceftriaxone, the flamethrower, the gram-positives and negatives at the same time and give Metro. But in exams, just know that. So I know GAM. I think other people have got different ways, like MAG, but I remember like GAMSAT for all these perfed viscous questions. But GAM, so gentamicin, amoxi, and metronidazole. So definitely know that one. So that definitely comes up. I don't know why. Cool. One's really hard. Sorry, who are we up to? Don't frown at me. We can all just do this one together if you like. This takes a few steps. So Brian's got pneumonia, and there's an air bronchogram on the right middle lobe, so that just shows that there's consolidation. That's what an air bronchogram means. It just means you can see the actual air spaces among the pus. And he's also got diarrhea. So what bacteria does he probably have if he's got diarrhea? And let's say he's also been to a potting mix conference in a hotel with a cooling tower. Yeah, awesome. So it's got Legionella. So Legionnaire's disease for diarrhea, one to remember. So is Legionella one of our SS Black gram positives? No. So the L is for Listeria. Awesome. So Legionella is gram negative. So we can rule out the gram positives. And what shape are most gram negatives? Rods, yeah, looks like a negative sign. So if you work through it that way, so diarrhea is Legionnaire's. Legionnaire's has to be gram negative, and most gram negatives are rods. So it's a gram negative rod. And it looks like that. That's a pretty hard question. So nice one. This is from Up to Date, and this is just showing that diarrhea actually happens quite commonly in Legionnaire's. As we went through before. Awesome. So what's the treatment? So there's 3 different severities of pneumonia using the CURB score. And they do teach us the different antibiotics to use. Do you guys know? So if it was super mild and you were just sending them home on orals, what would you give? Yeah, amoxicillin, or if you thought it was an atypical, you'd give something else. Doxycycline. Yeah, so amoxi or doxy. So note the or, it's only one of them for mild. And if it was moderate and you're admitting them to hospital, you give them 2 things. Do you know what those are? Yeah, benpen for the typicals, and for the atypicals you give, that's doxy again. Yeah. And then if it's super severe and you're really worried, so the CURB score is more than 3, what 2 things would you give? Yeah, ceftriaxone, so this other kef comes in, and one more thing. Azithro, yeah, awesome. So I think of AD, BD, kef, and azithro. So the AD is amoxi or doxy for the first 2. BD is benpen and doxy. And then ceftriaxone and azithro. Awesome. Interestingly, gonorrhea is the same treatment, which is ceftriaxone and oral azithro, which I find bizarre that we treat it the same as we treat really severe pneumonia. So AD, BD, kef, and azith. Cool. Awesome. So we'll rip through tuberculosis ones really quickly, because I think this might have been gone over as well. So standard short course is isoniazid, pyrazinamide, rifampicin, and one more. Which one's used in TB? Ethambutol, awesome. And what are the classic side effects of each of the 4? So rifampicin, orange urine, so you start pissing for rifampicin, orange blood. Isoniazid is peripheral neuropathy because of vitamin B6. Vitamin B12 is in alcoholics and vegans and Monash. Yeah, so B6, so you're given B6 instead. Pyrazinamide, this one's harder. Gout, awesome. So I think put out the pyre, so put out the fire for gout, so pyrazinamide or pyrazinamide. And then ethambutol is optic neuritis, awesome. So I think of ethambutol sounds like ethanol, and you get blind drunk on ethanol, so optic neuritis is ethambutol. Awesome. And then you give them for 6 months altogether. So you give them all for 2, and then you give the first 2 for 4 more months. So it's a 6-month course. And then if someone's getting prophylactic treatment, you sometimes just give them either rifampicin or isoniazid by itself. I think that's wrong. I think it's actually rifampicin usually. Cool. Does that all make sense? You're all down with your tuberculosis drugs? Cool. Just the last few questions now, and then we can all go home. Relax. So Sophie presents to a usual GP doctor. That's weird wording. Sorry. Complaining of a few days of feeling unwell and feverish. She had a root canal a few days ago. She's got painful nodes on the palps of her fingers. She's got Roth spots, and she's got a new pansystolic murmur. So what's the diagnosis? Yep, IE, awesome. Infective endocarditis, so infection of the lining of the heart. And for some reason, we get taught this as well. And I'm not sure if you would ever be asked on an exam, but this one's easy to remember. So what's the empiric treatment for IE? Yep, benpen, flucox, and gent. So that's the ETG page. So benpen, flucox, and gent. So I think of BFG, which makes it nice and easy. And the main bacteria are strep viridans, if it's more of a subacute one, and Staph aureus if they're an IV drug use and it's a bit more of an acute onset. And then if it's MRSA, you use V. I think you change the fluclox for MSSA onto the benpen. But the reason I think they do that is because fluclox and gent have a synergistic effect, where fluclox is a beta-lactam, so it cracks the dam, so it smashes open the wall, and then gentamicin can sneak in and start acting on that ribosome, so it inhibits protein synthesis. So they work together, which is I think why they keep them in the same spot. Yeah, so BFG, we don't need to remember that BFG, definitely keep it in your minds, which is not that hard. Barry Marshall has a history of peptic ulcers. He's got a positive urea breath test and past gastroscopy, which revealed a gram-negative helix-shaped bacteria. What are the three things you should use? The first line. So first line, sorry, I said not first one, but yeah, you're right, it's also the first one, sorry. So amoxicillin and a PPI, so I think of ACE. So amoxicillin, clarithromycin, and esomeprazole is usually the one I use, which is Nexium. And there's lots of second line things because there's building resistance. So I think of TOOM for second line, which is tetracycline, omeprazole, metronidazole, and bismuth, which is a good choice. I think that causes like a black tongue and stuff on exams, but mostly no ACE. So that could probably come up. So they seem to stress that a lot. So ACE, amoxicillin, and esomeprazole. What class is clarithromycin? It's got a throw in it. Macrolide. Cool, awesome. And that's just a page you can read in your own time, which is like the different types of therapy they can give. Cool, so we've got Sue, who was given ceftriaxone for pneumonia. She's now very, very unwell, and she's got watery diarrhea. And there's a gram-positive anaerobes. So what's the diagnosis? Yep, C. diff, which causes the disease. Yep, pseudomembranous colitis, awesome. So what's the first line treatment for that? It's an anaerobe. Awesome. Why is it not vancomycin? Why is that not also correct? Yeah, awesome. You have to give it orally because it's not absorbed very well, so it stays in the gut and kills off those bacteria in the gut. Cool, cool. So metronidazole kills anaerobes. One to definitely remember. I think we're on the last couple of questions. I stressed this one because this is something you had to know last year. So Samantha's 25, presents to a Melbourne GP. She's got hematuria. She's recently been Alice Springs. She had a very sore throat that was untreated. She's also hypertensive. So hematuria and hypertensive. So where's the disease probably? Kidneys, awesome. So she had a sore throat 2 weeks ago, but it wasn't treated. I should stress it's gone away now. So it's not Berger's disease or IgA, because that's synpharyngitis. You have IgA when you've got a sore throat at the same time. That's often a recurrent thing. Well, this diagnosis is often just a once-off. And the diagnosis is, yeah, so post-strep GN. Have you all heard of that? Yep, so glomerulonephritis happens from molecular mimicry from strep. It takes a few weeks to kick in. So what's that? Yeah, awesome. So gram-positive chain. So strep is a string, so it's a chain. And it's gram-positive because it's part of the SS, black. So one of the first S's. Nice work. Killing it. Does that all make sense? Awesome. Last few questions. Oh, I've been really keen on pushing what class is what for some reason, so I apologise in advance. I know why I did that. I read this a long time ago. So what class is minocycline? Tetracycline, so ends in cycline. It also causes vertigo, which is cool, but don't need to know that. What class is erythromycin? Macrolide, because it ends in thromycin. Look at the MacBook. What class is gentamicin? Aminoglycoside, and what are the two main side effects you need to know? Yeah, nephro and ototoxicity. Awesome job. Neisseria meningitis is gram-positive or gram-negative. Negative, what shape is it? Diplococci, I think the Diplodocus. Awesome job. Strep pneumo, is that gram-positive or gram-negative? Gram-positive, awesome. So what kind of things do you use against it? It's gram-positive. Yeah, beta-lactams, but yeah, benpen probably. So it's streptococcus, so it's a big chain, and it's purple because it's positive. Also, the last question is, why did that not come up? Oh my goodness. That's annoying. So the question was from a past exam, and it was, from memory, a woman's presented with a complicated UTI that's gone septic. She's treated with antibiotics, and then she comes home and she's just walking into walls and she can't stand up straight and she's super dizzy, and she also knows her hearing has gone missing. And then maybe you do a Rene, which is normal on both sides, but the Weber's test might lateralize to the contralateral side. So sensory neural hearing loss from antibiotic. What's the antibiotic? Gentamicin. Awesome job. Cool. And that's just showing for the gram-negatives, gentamicin is first line. And the ears, always remember if it's an ear and it's an antibiotic, it's probably going to be an aminoglycoside like gent. Oh, sorry. Good job, mate. Alrighty, so summary. Those are all the main classes, which hopefully look a bit more familiar now than they did before. That's the mnemonic to remember them all if you feel particularly inclined. And if you look at that big list of classes from AMH, which I definitely recommend looking up for all your little drug facts, not just antibiotics, you can see we've actually sort of seen ones from all of the classes. And that's about it. So remember, so hopefully we can now recognize which class is pretty much, be able to pick which bug is which. And we've gone over the MCQs. Definitely don't forget beta-lactams are good at killing the gram-positives, so they crack the dam. Gentamicin is really good at killing gram-negatives. It also causes oto and nephrotoxicity. Metro is really good at killing anaerobes. And vancomycin kills MRSA. I'd really recommend putting up a little drawing on your bedroom wall and highlighting it as you see stuff over the next few years so it sticks in your head. And that's about it. You guys smashed it, so I think you'll be pretty fine for exams. So good luck. Thank you for listening. That's all right. Oh, I think I might have actually stopped recording at that point. I wouldn't be surprised.
That's all right. We'll find out very soon. No,
Still going?
Still going.
Cool.